Okay, good afternoon. Thank you all for coming. This is the iHEA Student Paper Prize session. All but one of our prize winners from the last 2 years is here. Unfortunately, one couldn't make it. But everyone else has, so thank you very much to all of you for coming. Thank you very much for all of you for coming to the Paper Prize session. And we have the two first prize winners from the last 2 years. I'll have a little bit longer to present, and then a few minutes for questions. And then the other prize winners will have a little bit less time and a little bit less time for questions. But we'll get a flavor of everyone's work. There were a lot of submissions in both years for the prizes, so everyone who's here should be really pleased that they got a prize and won, because it was very close and there were some excellent papers. And you'll all get your certificates later, so don't forget to come. The next prize will be open for submissions in October. So if you're watching online or you're here and you've got students or you are a student, please think about submitting your full paper for consideration. So that's the advert over with. I think we should get on with it now, because you haven't come to hear me talk about the prize. You've come to hear the talk about what the actual prize winners were all about. So we're going to go in order, and we're going to start with the first prize winner from 2018, because remember, iHEA is every 2 years, but the prize is every 1 year. So we'll get cracking. First prize in 2018 was Mujaheed, who's here. Do you want to come up? And the title of Mujaheed's paper, and Mujaheed's from Vienna University, is Your Retirement and My Health Behavior. So thank you, Mujaheed.
Thank you very much. Well, I can hear that you can hear me, so it's fine. My name is Mujaheed, and this paper is joint work with Tobias. I share the prize with him, therefore, and he's a very sharing co-author. He's also going to share my questions at the end. As you can see, this paper is called Your Retirement and My Behavior, Evidence on Retirement Externalities from a Fuzzy RDD. Before I begin, I'd like to tell you that retirement is a very important topic, not because I have a paper on that, but also interesting for academia and policymakers. Just in 2017 and 2018, there were about 6 papers on retirement and health in the Journal of Health Economics alone. So that's very interesting for academia. It is interesting for policymakers as well, and I'll tell you why. There are 3 facts why it is interesting for policymakers. So we all know that something like a financial crisis is very bad for physical and mental health. But do we also know that crises occur at key demographic turning points? There was an article in the Financial Times in 2016 which showed that the Japanese crisis in the 1990s, the US crisis, and the Eurozone crisis all occurred at very important demographic turning points, which was basically when a large number of individuals moved out of the labor market into retirement. So this is a very important topic. 10,000 baby boomers turn 65 every single day in the US alone. Within the OECD, the number of years now you can expect to live as a retiree has increased from 11 to 18 years as of 2012 for men, and 15 to 23 years for women. So this is clearly important. Now couple this with the fact that we've made amazing progress in terms of living longer, in terms of life expectancy. In fact, there was an article recently in Nature which suggested that, at least theoretically, there is no ceiling to life expectancy once you cross 90 years, so we can expect to live forever then. So you and I would be very happy about that, but policymakers are not, and they have genuine reason to worry about that. And the reason they're worried is because people will live much longer as retirees, which means they'll draw much more from the pension funds, but contribute much less throughout their working life. So it calls into question the sustainability of the financial viability of pension systems, and that is why it is worrying. Of course, they have to do something about it, and what they think of doing about it is, 1, they can cut pensions, which is politically very infeasible. Second, they can provide incentives for people to actually retire later, stay longer in the labor force. And third, a very common thing is increasing the retirement age. However, there is a large literature now on retirement which talks about several social and economic effects of retirement. So it affects income. Income replacement rates in the EU are very low. It affects consumption behavior, expenditures, it affects leisure activities. And what is of interest to us health economists is that it affects health and health behaviors. Now let's pause for a moment over here and think about yourself at the age of 65. You have retired now. How do you picture yourself? How do you imagine yourself? Sitting on the beach having a nice drink? A lot of us would also imagine ourselves with engaging in activities with our children, with grandchildren, and most importantly, with our spouses or partners. And that's precisely what we touch upon in this paper. The literature on retirement actually largely ignores these externalities. There are some papers which look at marital outcomes, and there are some which look at joint leisure. There's nothing, literally when we did the paper 2 years ago, there was nothing on retirement externalities in terms of risky health behaviors. Why would you expect such externalities? It is very clear. Retirement is a very, very important event for an individual. It's not just the person that is stressed out, it's also the people within the household that are stressed out because of that. Second, there's a large literature also on several endogenous and exogenous social effects. There's the literature from education, from savings, and from technology adoption, which looks at these intra-household retirement externalities, and they do find such externalities to exist. So why would we not think about these when it comes to health and health behavior and retirement? That's precisely what our research question is. We are interested in looking at the impact of partners' retirement on your own health and health behavior. So we identify these intra-household retirement externalities by looking at health behaviors such as physical activity, smoking, and drinking. We also look at the implications on health. In addition, we also try to identify own effects of retirement on health and health behavior. We look at several ways of heterogeneity. We look at gender heterogeneity, heterogeneity with respect to smoking status, drinking status, and the timing of retirement. And eventually, we try to see what the net impact is of your own retirement and your partner's retirement on health. Our contribution is very clear. It's the first paper to show causal behavioral externalities of retirement. It directly contributes to the literature on determinants of risky health behaviors. Prior literature does a fantastic job at analyzing the effect of retirement on health and health behaviors. However, it does not incorporate spousal retirement into the empirical models. And this is very important because spouses, couples, jointly time retirement. And it is important to account for that. And we believe that our paper imparts new insights for legislative changes, especially with retirement ages. So how do we do this? We use data from the Survey of Health, Aging and Retirement in Europe. It's a multi-country European survey. It has several sections, a large section on health and a large section on labor participation as well. So we use 4 waves from the SHARE survey from 2004 to 2013. We include 19 European countries. In terms of the sample that we have, we use only those individuals that are within a window of 3 years on either side of the country-specific official retirement age. We look at only those individuals who we have information for the partner as well, so both of them participated in the survey. We end up with about 23,600 observations with missing values in some of the outcomes. So the variables, of course, since we are interested in retirement, we're looking at the retirement variable itself. It's a binary variable. The individuals self-report whether they are retired or not. In terms of the outcomes, we look at physical activity. So we look at 2 things, moderate physical activity and vigorous physical activity. So a question is asked, how often do you engage in moderate activities like gardening, cleaning, and so on? And the other question is on vigorous physical activity. How do you engage in vigorous sports, for instance, high-intensity sports? For smoking, we have 2 indicators, which is whether you currently smoke or not, and how many cigarettes you smoke per day. With the cigarettes, we also do 2 things. We look at a specification where we include the non-smokers as well, so they're all zeros in that, and then we look at a specification where we have only smokers. So then we look at the intensity of smoking with that. For alcohol consumption, we have a few indicators as well. We look at the frequency of alcohol consumption, how often do you drink. We look at the intensity of alcohol consumption, so how many drinks per day, and whether you engage in binge drinking, which is more than 5 drinks on one occasion. And we also look at if you've got a drinking problem. Finally, we look at subjective health status, which is from poor to excellent. Now, how do we identify these effects? Obviously, retirement is an endogenous decision, so that you can have omitted variable bias. So for instance, if there's a possibility for grandparenting, you would choose to retire earlier, but that also means if you're close to your grandchildren, you might engage less in smoking. So that causes a downward bias in the estimates. There is reverse causality because health itself affects the retirement decision. So given these endogeneity problems, we address this by using a classic regression discontinuity design, which is also common in this literature. I think most of us know what an RDD is, but just to be very quickly on that, we simply look at those individuals that are just above the country-specific retirement threshold and those that are just below the country-specific retirement threshold. These individuals, given certain assumptions, should be similar to each other, except that one retired and the other did not. So that's what we do with an RDD. We perform a standard validity checks that I will show you, and then we look at the discontinuities. So the first assumption is that the running variable, which is age, which determines whether you'll be treated or not. Age of 65, you're treated. If you're below 65, you're not treated. We check if the individuals can manipulate this. We do not find any evidence for that when we do a simple density test for it. On the x-axis, you've got centered age. The centering is done at the country-specific official retirement age. Then we look at the discontinuities in other variables that ideally should not change at retirement. For instance, we look at number of years of education. We look at gender. I would strongly suspect why that would change. And the number of kids. We do not find strong discontinuities over there. We also run regressions with these variables as outcomes later on, and we do not find any significant effects over there. So we then say that we have a valid RDD design. The next thing is to decide what the empirical model should look like. We, in a way, follow Stantonelli and So's paper on this, where they look at household consumption. It's very simple. So YI is basically the outcome for individual I. It could be health, it could be physical activity, smoking, and so on. We are interested in the impact of DPI, which is individual I's partner's retirement status. D is equal to 1 if retired, 0 if not. But we also include D itself, the retirement of the individual in the equation. Now, some individuals obviously retire, which naturally leads us to a fuzzy regression discontinuity design. The probability to retire at the country-specific age is not 100%. So we end up with an instrumental variables estimation over here. We instrument D with T, which is the treatment variable. So it is 1 if the individual is above the official retirement age of the country, and it is 0 if he's below that. So we instrument both individual retirement and the partner's retirement with that instrument. Then we check if there's actually a discontinuity at the official retirement age. Again, on the x-axis, you've got the centered age, centered at the country-specific retirement age. On the y-axis, we have the probability of retirement, and we observe that as individuals move closer to the official retirement age, this probability slowly rises, and then there's a discontinuity exactly at the country-specific age. So we find very strong first-stage effects. Our F-stats are very high, and we do observe what we should have observed. I'll jump straight into the results then. So next, the first indicator, as I mentioned, is physical activity, which is moderate physical activity and vigorous physical activity. We find that partner's retirement negatively affects moderate physical activity by 5 percentage points. However, own retirement is positively associated with moderate physical activity and vigorous physical activity both. We look at smoking. We do not find any impact of own or partner's retirement on smoking variable, which is a 1-0 variable, and the number of cigarettes smoked. But these specifications include the non-smokers as well. When we separately evaluate only the smokers, we find a very strong impact of about 16 cigarettes per day. We then look at alcohol consumption, and if we look at partner's retirement, it affects everything positively. So you actually start drinking more, you drink on more occasions, you have more drinks, you engage in binge drinking, and you end up with a drinking problem. You observe the same thing with retirement as well. However, the effects are much larger for partner's retirement than own retirement. As an additional exercise, we also look at retirees and non-retirees separately. So we fix the retirement status of the individual, and I will show you those results in a minute. Eventually, we want to look at what the health status is, how it affects net health status, and we find that partner's retirement affects your health negatively, your own retirement affects your health positively. Then, as I mentioned, we fix the retirement status, and after fixing the status, we find very strong effects for cigarettes. So this is only for retirees. So you are retired, and then we look within all the retired individuals, what happens to you when your partner retires. We do the same thing with non-retirees, and we find similar effects, but a smaller magnitude. It's much larger for if you are retired and your partner is retired, pointing towards complementarity of the retirement effects. We do a lot of robustness checks. We use different polynomial functions. We change the window width to 1 year, 2 years, and 5 years. Obviously, with the 1 year window width, we have a very small sample, so we've got a bit imprecise estimates. We include a lot of control variables. We use country-specific models as well. Very important is to find any effects over there. So basically, we exclude this sample. When we exclude this, we still find what we find, and that's why we are taking care of something which past literature has not done. We do a lot of placebo tests as well. We use fictitious age thresholds. As I mentioned already, we look at predetermined variables as outcomes as well. So to conclude, in sum, overall, what do we find? We find that partner's retirement decreases physical activity, increases alcohol frequency, increases the amount you drink, and increases smoking. Bad. Own retirement increases physical activity, but also increases alcohol frequency. There's no effect on smoking and alcohol. So And there's a positive impact on health, there's a negative impact on health over here. That's what we find overall to sum up all the results. Now, once we know this, how is it going to, affect policy making, or how should we think about this? So, if you think about the individual, obviously it has adverse impacts on the individual himself. So there are costs to self of this. Also, because income is reduced, you have a tighter budget constraint now. But if you engage in more smoking, you spend much more on cigarettes, you will have probably less money to spend on other healthier activities. So that could be affected. What we also observe now is a lot of companies offering retirement training to individuals. So individuals in the US, for instance, sign. So why not have public health strategies which promote those kinds of activities? At the societal level, obviously, if it's a cost to the individual, it's a cost to the health system as well, especially in Europe, where most countries are universal health coverage, and it's going to be a big cost. What we also observe real quick is that if you separate retirees and non-retirees, you see that the health impact is much lower, and it's much higher when you are not retired of your partner's retirement. So what this means is that your negative health effect of partner's retirement is probably balanced with the positive health effect of your own retirement. So why not look at converging male and female retirement ages if that's going to balance it out? And of course, before framing policies, regulators and policymakers should internalize these costs and benefits. That's it. And I would really like to thank all the people that read my paper in detail when this was, when we sent it out to them. So these are those people. So thank you very much if you're here. Thank you. That's it.
Thank you, Mujaheed. Perfect timing. Okay, we've got a few minutes for questions now.
Yep.
Please, can you say who you are first? That would be nice.
Thanks. Thanks for your presentation. I'm Marianne Tenand from Erasmus School of Health Policy and Management in Rotterdam. And so just a remark about your kind of policy recommendation about converging ages for retirement for males and females, but what do you do about the fact that people tend to have different ages when they mate? So males tend actually to be older than females. So
yes, so that's right. In most settings, males tend to be older than females. So, however, if you also notice that female retirement ages, I didn't show the table where we have the retirement age of each country. Female retirement ages are also lower than male retirement ages, on average by about 3 to 4 years. So I think there is still scope to increase female retirement age to bring it to the point of male retirement age. But again, we are not saying this as a definitive solution to this because there's still a lot more that needs to be investigated. This could be one of the things that policymakers could think about. But as I said, there are many, many, many social and economic effects, and this was the first paper that we did, but there is so much more to do in health and outside health as well in this area.
Okay, thank you. One here and one here.
Thanks. Oh, okay. I'm Crystal. I'm from Imperial College. Thank you so much for your presentation. I had a couple questions that I'm not 100% sure you talked about because you talked very quickly. The first
time limit.
It's okay. The first is, I don't know if you did any subsample analysis by gender.
Yes.
So
yes, we did.
If my partner is a male or
yes.
female, do I have worse effects or not?
Yes, so we did a subsample analysis by gender, and we find that it is the man's retirement that affects the woman more. It's not vice versa.
Great, and then my second question is, so basically if your partner retires, you have negative consequences on your health. Do you have any intuition as to why that might be?
Oh, so what we have in our paper is subjective health status, which is physical health basically, and there is another paper by Bertoni and Brunello, which was published in 2017 in Social Science and Medicine, which looks at mental health effects in Japan, and they find that a lot of these effects are because of stress that these women usually have when their husband comes into the picture. It's purely mental health.
All right, so great presentation. My name is Adrian. So I was just wondering, intuitively the story for me is I actually don't really like my spouse, and once they retire, now I'm not having fun.
I agree.
And so I wonder whether you have data on whether they get separated or divorced, and whether that can fix, like, is that a solution to
yes,
this?
so two things. Yes, one, there is a paper which actually looks at marital outcomes, divorce, and they find that retirement actually increases. There is more divorce at retirement. However, in our data, since we look at only couples staying together, we do not know if they're divorced with the same couple, so we can't do that in this paper. But yes, it does have an impact on marital quality. You start hating your spouse more at retirement because there's someone in the house that suddenly came and stays all day at home doing nothing, interfering with all your activities. Obviously, you will not like that, so.
Okay, well, we're very tight on time, but thank you very much, and we've got some good questions, and that discussion certainly gave several of us in this room something to think about. So thank you very much. We will. Thank you. So our next speaker is Monica Aswani. Monica won first prize this year, so she's the current first prize winner for 2019. Do you want to come up, Monica? Monica Aswani is at the University of Alabama at Birmingham, and the paper is Differential Impact of Hospital and Community Factors on Medicare Readmission. So thank you, Monica.
Can y'all hear me? Yes, okay. So it's an honor to be here and to receive this award. I'd like to just quickly acknowledge iHEA funders and my dissertation committee for spending many years putting up with me. And I'm gonna do a really quick personal note, which is I saw this tweet this morning and it sort of made my day because I had a slide that I kept wavering on and solidified my resolve to keep it in here despite the live stream and that this will now be memorialized on the iHEA website. And so I sat in this very audience 2 years ago at the Boston Congress. It was my first iHEA, and I sat there convinced that this would never be me. And I've literally given you the screenshots, the emails to prove it. And the first email is from 2016, and it's an economist in my department that emails my chair to say, you know, perhaps Monica should consider this, and I respond, I don't really think my paper's econ enough. We go through that the next round, give the same reason, and unfortunately I'm rather embarrassed to say I gave the same reason this year. But my chair passed away a month before I defended, and I felt like we had had that conversation multiple times, and in honor and memory of his legacy of mentorship, that I should at least submit an application. So I reached out to someone on my committee, and I gave the same exact reasoning, like I had not sort of grown and matured the way I would have hoped to tell you 3 years later for the record. But I did submit it, and I'm standing here in front of you. And so I don't know if there are any students that actually do relate to how I felt 2 years ago, but if so, or if someone happens to watch this live stream years later, what I sort of really hope is to impress one message upon you, which is, you know, I may not be proud of either of these, but they're two very different mistakes, and the one on the left is a self-fulfilling prophecy of failure, and the one on the right is conditional on trying. There's at least a non-zero probability of success, and that's how I'm standing here. And so, right, this is survivorship bias, but that can work in your favor, which is no one sees the many failures and missteps and rejections that I think we all go through, and it's hard to remember that when you're sitting there. So apply, keep working hard, and on that note, I worked really hard on this. It's my first dissertation paper, and I get to geek out about it, so thanks for having me. So quick background, the Hospital Readmissions Reduction Program penalizes hospitals for excessive readmissions for certain conditions. That condition set has expanded over time, as well as the maximum penalty that hospitals can be penalized. Now, the program has had some controversy over the risk adjustment. It adjusts for gender, age, and illness severity at the patient level. But the literature has had mixed results on the relationship between social risk factors and readmission risk. And so this is a great infographic. It's not mine, but it looks at various things like income and education level and shows that the literature has really found very different results depending. And so to address that concern related to social risk, the program starting in fiscal year 2019 ranks hospitals based on their quintile of the proportion dual-eligible patients they serve. So Medicare, Medicaid, it's typically a sicker and poorer population, and that's what it's doing. And so given that, my objective for this paper was to study the role of contextual factors in readmission penalties and identify hospital and county factors associated with them. And that sort of first part is the part that I'll gloss over very quickly because I don't think the results will surprise any of you sitting here, to be quite honest. But I think the second part is what gets interesting, and I investigate sources of regional heterogeneity and readmission penalties, and I think what I mean by that may sound a bit amorphous, but hopefully it'll become clearer in a second. And so I use a variety of data sources. Another note, if you're a student, don't do this. You don't need that many data sources in that many years, but I was determined. The one quick note I want to make on the slide, though, is I did create a composite for HCAHPS. So HCAHPS is a patient experience survey, and so essentially the most favorable response to every question, the percent sort of top box, was averaged across all questions, and the Crovax alpha was 0.94, but that's sort of the main point, and I'm just trying to capture a variety of constructs at the hospital and county level. Now, I mentioned earlier that the maximum percent penalty had increased over time from 1% to 3%. That puts me in a bit of a problem because I'm going to do something economists in the room, and I'm going to apologize in advance, will find rather blasphemous, which is I'm going to collapse longitudinal data here. And what would be really nice is if I could just sum across. And if you look at hospitals B and C that I'm giving you an example of, they're both penalized the maximum amount every year that they're in the program. But hospital C actually isn't in the program that first year. And that can happen for a variety of reasons. Maybe it doesn't exist, maybe it doesn't meet the minimum case threshold, which is 25 cases for each condition. But if I sum, I'm sort of conflating, not eligible or missing with not penalized. And for whatever reason, again, I felt the need to address this, and so I went through various constructs, and you can see how the relative ranking changes depending on the denominator I might choose. And I ultimately decided to create my own outcome, which I'm going to call the share from here on out, and it's essentially the sum divided by your theoretical maximum penalty. That's the only outcome for me where hospitals B and C look the same, and that's important to me. Okay, so I have hospitals nested within counties. I have about 3,000 plus hospitals in 1,500 counties. I have about 25% singletons for the record, so they're the only hospital in that county, and that will become important later. And as I've already unfortunately warned you, I did that and collapsed my longitudinal data away, so I at least have a two-level model. Now what's interesting here, right? We're in sort of our normal world where I have to choose methods, and it's fixed effects or random effects. And I actually really meant to go back and do this because I screenshot someone's slides from Dartmouth, and my apologies. Hopefully you can appreciate my cheeky humor if you're somehow in here, right? I generally agree that we all love fixed effects. That said, for the question that I'm looking at, right, this is one of my favorite things ever, fielding something of a renegade economist, right? It's only a random effect specification that can handle level 2 covariates, right? And I'm sort of a big fan of this in the sense of it's essential to my question when I care about county level factors and how they're associated with readmission penalties, that I'm able to get coefficient estimates on them. And so what was happening at the beginning of this paper was I would do the fixed effects and the random effects model and compare certain things and have disparate results, but I really want the random effects model, and I'd say, well, what do I do now? And so how am I going to address this? And I'm sorry, I don't sort of know what happened to the equation up there, but you're going to hear some really exciting papers in this session. You've already heard a fuzzy RDD. I know there's going to be an instrumental variable later. I'm going to argue that I think the novelty of this paper is I'm elevating the humble average. And so what I do is I basically just put in a vector of county means of hospital variables. So if there's 4 hospitals in a county, for example, 2 are teaching, 2 are not, they would have a 1, 1, and 0, 0 respectively on the teaching variable, but then I'm also going to have a county average where they all have a 0.5. And what is that allowing me to do, right? Our main concern whenever we have a random effects model is that violation of the level 2 endogeneity, and I can relax that assumption. But more importantly, it's also allowing me to do a Houseman-type test on each individual covariate. And so our within here is our normal fixed effects, and hopefully it's fairly obvious that the within plus contextual equals the between. But counties don't get penalized, and I only need to get 2 of these, obviously, to get the third. And what I'm really interested in here are contextual effects. So what exactly is a contextual effect? For 2 identical hospitals, including their value of the X variable, I want to know, is there a significant difference in penalties for a hospital that's located in a county that on average has 1 unit more of the X variable? And that's what I'm interested in here. And so, right, I've arguably spent, like anyone who's sort of great at public speaking and, they post those slides on Twitter of like how to give a podium talk, I've spent way too long on methods. And so was that necessary? And I'm going to argue yes. right? And the first pass thing is I have a lot of variation at the county level in readmission penalties, about 35% for the record. And that's in the outcome, that's the share that I created. It's actually higher if I just use the raw sum. And if I look at some individual fiscal years, it can get almost as high as 50% for the record. So now what I'm going to show you are two models. They both have the Munlach regressors, so those county means of hospital variables. But the first model only has the hospital variables, and the second model will also include the county level variables. And so here I have penalties, and unfortunately the arrows went away, but teaching status and patient experience are associated with lower penalties, and private for-profit status and percent Medicare and patient days are associated with higher penalties. Now what happens when I add county level variables? Well, these are fixed effects, right? So nothing changes. Had something changed, I would have been in trouble. So here's the bottom half of that table, because I'm just splitting this up so you can read things on the slide. And there's a variety of characteristics related to access to care, quality of care, that are associated with readmission penalties. Again, I don't think any of this is particularly surprising for anyone who works in this space. Here's where I think we get to some of the more interesting results. So I'm only presenting the significant contextual effects here. And again, these are the county means of the hospital level covariates. And what is this telling me, essentially? These are the variables that are actually absorbing that bias so that I can get fixed effects, but they're letting me know that they're correlated with unobserved regional characteristics. And that exists for percent Medicare days, percent dual, percent Black patients, and the HCAHPS composite. And when I add county level variables, 2 of those go away, and 2 are attenuated, basically. And it's also giving me a sense as to the degree, right, of unobserved regional heterogeneity, just those coefficients. But what does that actually look like? And so I'm going to try and walk through this, right? And so percent dual, I think, is the most interesting and policy relevant, just given the program change starting in fiscal year 2019. And so if we look at the within, I have no evidence to suggest that there is a significant difference in mean penalty share based off the relativity of 2 hospitals within any county. However, right, it's this contextual effect right here that's suggesting that there are meaningful differences for 2 similar hospitals, including the percent dual population they serve, but that are located in counties that differ on their average values of percent dual population. And to carry that forward, that effect is attenuated once I add in county level variables. So I've tried to make that image on the right smaller. And right, just to quickly walk you through the rest, there's the within effect for percent Medicare days and a contextual effect, and it's slightly attenuated, but not by much, with the inclusion of county level variables. For percent Black patients, there's only a contextual effect. With the inclusion of county level variables, it completely goes away. And finally, for the HCAHPS composite, there's a within effect and a contextual effect, and again, that contextual effect disappears with the inclusion of county level variables. And so what's the summary here, right? There are a variety of hospital and county level characteristics that are associated with readmission penalties. 1/3 of the variation in penalties is at the county level, and there are contextual effects for a variety of characteristics related to the patient population that the hospital serves. And I think, what are the policy implications now? There's a relatively high degree of homogeneity between hospital readmission penalties within the same county, and I think that that's telling. I might argue that I think geography and hospital characteristics are sort of unsurprisingly correlated, but the larger question is to what extent are these area level factors within a hospital's control? There's also a parallel to be made, which is the program itself uses a random effects model, essentially. It's a more advanced one, but it is a random effects model at its heart, and it has patients nested within hospitals. And it doesn't include any hospital level attributes, so it has the same parallel potential for bias. The limitations. I warned you earlier that about 1/4 of my sample is singletons. So they don't contribute to those within estimates, obviously. They don't have a peer in their county to contribute to those, but they do contribute to the estimates on the county level variables. I did collapse longitudinal data. The models get really unwieldy when you have too many levels, particularly because the county level averages of hospital characteristics, you're getting into a lot of collinearity there as well. I didn't address the skewed nature of the penalty outcome. I did at one point, and it just didn't really change the results meaningfully, and it complicated the interpretation. And ultimately, right, the variables are really aggregated proxies of the things that I'm interested in. Thanks.
Thank you, Monica. Questions? Yes, please.
So, so I understood that teaching hospitals have lower penalties.
Yes.
Yeah. Do you know why? Because I would imagine the opposite case. They get more complicated cases. They do a lot of activities like treating patients and also teaching and research and so on. So do you adjust for case mix somehow?
I do not, and I don't for the reason that the readmissions themselves are adjusted for illness severity, and so it would feel like a double adjustment for me to adjust for case mix on top of it. So I don't adjust for case mix. I do think there's some sort of potential to be said that teaching hospitals likely, one, are located in communities where they're able to perhaps actually do the things the program intended, for example, like coordinate post-acute care relationships. A lot of them were likely ahead of the curve too. So for example, discharge planning kits started coming out, in 2009, 2010, a lot earlier than, penalties started taking place. And for teaching hospitals, they may have been early adopters of those type of efforts. So discharge planning, medication reconciliation, et cetera.
Okay, right in the middle, thank you.
Thank you. That was really terrific, Monica. Meredith Rosenthal from Harvard T.H. Chan School of Public Health. So I just wanted to ask you a little bit more about your policy recommendations here. Of course, as you stated, and you know well, the Congress has asked CMS to look at this issue, and this little step that was taken in terms of making adjustments for dual eligibles is the first part of that. But what do you think Medicare really should do, given what you found in terms of updating this payment policy to presumably make it more effective for improving care rather than just penalizing the same hospitals over and over again?
So I think that's a great question, and I think the answer is twofold. For me, I think the first part is to sort of do the analog of this in their model, right, which is to see, so for example, in illness severity, it wouldn't surprise me if stroke was correlated with hospital-level intercepts, right? I'm from the Deep South. Alabama is sort of red on any given map for stroke, for example. And so I think trying to recognize what parts of their risk adjustment algorithm are actually correlated with the hospital-level intercepts that they're using in their model would be equally important. I think the other thing is to think about how, so it's one of the pay-for-performance programs that doesn't use any higher level fixed effects, whereas others like dialysis do. And so I think thinking about the implications of that and the potential bias, and I think the only way to really do that is to first say, what is the potential magnitude for bias that we have? And right, that's sort of what this does here, but in a different context, because I'm also interested in the community level factors, but I think that's sort of their first part. And then I think their second part is to say, depending on what we find there, do we want to consider implementing some sort of adjustment?
Okay, thank you. Are we all done? Okay, Monica, thank you very much, and congratulations again.
Thank you.
So our next speaker is Ana, who's coming up. Ana Rodriguez-Gonzalez from Pompeu Fabra in Spain. And the paper is, It's About Time, Cesarean Sections in Neonatal Health. Ana was second in 2018, so congratulations.
I think that's okay. So I'm going to try to briefly summarize our paper on the impact of cesarean sections on newborn health. This is joint work with Ana María Costa, with whom I share the prize, and our colleagues Miquel and Carlos. So there's been a lot of debate in recent years about the rise in cesarean section birth, because even though we know that when C-sections are needed, they save lives, they've also been associated with worse neonatal and infant outcomes and also worse maternal health. However, we know relatively little about the causal nature of this relationship because most of the studies up to date, or at least when we carried out this study, were based on comparing in more or less sophisticated ways the health of babies born by C-section and the health of babies born by vaginal delivery. And these two groups are very different in a lot of observables and probably unobservable characteristics. So with comparations like that, it's hard to disentangle the effect of the C-section itself from the effect of these other differences. Why should we care about the impact of C-sections? Well, the literature has recognized the lasting importance of a lot of early circumstances and shock, or a wide array of outcomes that we care about. From other perspectives, C-sections are also more costly for health systems than vaginal delivery, so it's important to know what benefits they bring, at least in terms of maternal and infant health. So in a nutshell, in this paper, we want to contribute to fill this gap by providing credible causal evidence of the impact of C-sections on infant health. And to do so, we're going to exploit variation that we find in the probability of having an unplanned C-section by time of birth that we find is unrelated to maternal characteristics. So we'll be comparing mothers who give birth in the same hospital and are similar in observable characteristics, but that depending on the time of birth have a higher or a lower probability of having an unplanned C-section. We do so with data from 4 public hospitals in Spain. And just to give you a preview of what we find a significant negative impact on newborn health measured by Apgar scores at the minutes 1 and 5, which is a summary measure of neonatal health. But we find that this effect is relatively small when compared to the associations of previous literature, and consistent with this, we do not find that C-sections lead to higher probability of intensive care unit admission, assisted ventilation, or neonatal mortality. So with this paper, we contribute to the literature by providing what we think is the first credible causal evidence of the impact of avoidable C-sections on neonatal health. And we also provide a new instrument using time variation in C-section rates that allows us to abstract from cases where C-sections respond to a clear medical indication. So very briefly, as I said, we use data from Spain, from public hospitals. There are private hospitals in Spain, but most of the deliveries take place at public hospitals. How it works is that midwives are the ones that take care of most of the delivery, but obstetricians are the only ones that can decide on the mode of delivery and intervene if there are complications, and in particular perform C-sections. What's going to be relevant for the identification strategy we adopt is that obstetrician shifts normally are from 8 a.m. to 3 p.m., but when they're on duty, they have to stay in the hospital for 24 hours from 8 a.m. to 8 a.m. next morning. So this is the variation in the unplanned C-section rate that we find. This is the probability of unplanned C-section by time of birth. And as you can see, it is not uniform. We find this a substantial peak in unplanned C-sections at the beginning of the night, in particular from 11 to 4 a.m. This is higher than 15%. Now, the first thing that may come to your mind is that the mothers giving birth at these times are different from the mothers giving birth during the rest of the day. But in fact, this is not what we find. In this table, I'm comparing demographic, background characteristics of mothers and also pregnancy characteristics between those that give birth during the early night and the rest of the day. And as you can see, they are quite similar with regard to most characteristics, and in particular regarding pregnancy and delivery characteristics that could predict a C-section, like obstetric risk, or gestation weeks, or whether they have had a previous C-section, and so on. So we conclude from this that selection of different mothers is not explaining our variation. What explains it then? Well, we're not the first to identify this kind of peaks. Previous studies have already found similar peaks in unplanned C-sections during the evening hours. These studies argue that because of the higher time cost of surveillance implied by C-sections with respect to the higher time cost of surveilling whole vaginal delivery with respect to C-sections, in those cases where the opportunity cost of time is higher, the incentive to perform a C-section, at least in ambiguous cases, may increase. This is consistent with the pattern that we find in our context, because in the moment where we find these peak in C-sections, doctors have already been working for a lot of hours. They do not, they're medium to small hospitals, so its delivery accounts for a major part of their responsibilities. But in any case, with our data, we cannot single out the reason why this increase takes place. But we do provide some suggestive evidence consistent with this explanation. We find that this peak is not explained by medical emergencies, it's not explained by accumulation of induced births, and we also find that this increase is larger in nights when there is only one birth going on at the hospital, which is when the marginal benefit of performing the C-section in terms of saving times would be larger. What is important for us in any case is that there is a change in medical criteria that is not related to the underlying health of the mother or the baby. So this is what we need to have this exogenous variation. So very briefly, our empirical strategy is going to exploit this variation. We're going to use an instrument for birth during the early hours of the night as an instrument for an unplanned C-section birth. So the endogenous variable here will be unplanned C-section birth and dummy variable. We're going to control for hospital fixed effects, weekday fixed effects, and a lot of maternal and pregnancy characteristics. And our IV estimation will give us a local average treatment effect. So we'll capture the effects of C-section for mothers where the decision to perform the C-section was affected by the time of the day. And we're going to examine several indicators of neonatal health. The main one is the Apgar scores, which, as I said, is a summary measure of neonatal health. It's a scale that takes values from 1 to 10 and measures things such as skin color, heart rate, respiration, and so on. So I think this is a good summary of the results we find. Here in the IV coefficients for the impact of an unplanned C-section on the probability of having Apgar scores lower than 10, lower than 9, lower than 8, and for the different thresholds. So we find that these unplanned C-sections that are performed because it's the beginning of the night increase significantly the probability of having Apgar scores at the minute 5 lower than 10 and lower than 9, and there seems to be a non-significant increase in the probability of having them lower than 8 as well, but we do not find anything for lower thresholds. So there's some negative effect, but it's relatively small. Consistent with this, we do not find effects on intensive care unit admission, assisted ventilation, or neonatal mortality. We perform a number of robustness checks that, for the sake of time, I do not have time to cover. The most important one is that we provide evidence that it's not different quality of care at the beginning of the night that is explaining our results. So we also exclude inductions, perform some placebo test, and we show that our results are robust to using the time of admission instead of the time of birth as an instrument. So from this, we conclude that, well, basically summarizing in this paper, we provide causal evidence of the impact of C-sections on neuron health using a novel instrument. We find negative effects on Apgar scores, which is limited to these normal but still relevant levels. But we can rule out very severe impacts at birth, in contrast with the findings of previous studies. So these other studies may have been capturing, at least in part, this underlying worse health of babies that undergo a C-section rather than the impact of the C-section itself. We think that more evidence is needed to understand the long-term impacts that C-sections may still have, because one of the most prominent hypotheses in the medical literature is that exposure to the maternal vaginal microbiota is important for the development of the immune system, and this is something that we may not be able to see at birth. And more research is also needed to understand the medical decisions driving this variation that we find. And with this, I can conclude. Thank you very much.
Thank you. Thank you, Anna. Okay, questions. Hand up already. Thank you. Hang on, Rachel.
Rachel Morton, University of Sydney. Thank you very much, Anne-Maria. That was really interesting. Did you look at the effect of weekdays versus weekends? So you're talking about overnight, but I'm wondering whether there were similar effects when you looked at Saturdays or Sundays.
We control for the type of day where the birth takes place. So this is within type of weekday, but I don't think we've looked at different heterogeneous effects, let's say, by whether it was a weekend or a weekday. But the effect of the weekday itself, it's taken care of with the fixed effects. But no, it would be an interesting thing, but we have not done that so far. Thank you.
Thank you. One more question.
Okay. Tobias Müller, very excellent presentation, first of all. I was wondering if it's possible to somehow rationalize the decision of mothers to opt for these avoidable C-sections. I think I read about, there's less complications for the mothers. So couldn't it be, that mothers simply trading off the benefits for them with the costs for the babies? I mean, what you're showing is that, there's costs for babies, but it could be the benefits for the mothers are bigger than the costs for the babies. I don't know if you can say something about this.
So we cannot say here what really if it's more the decision of the doctor or the decision of the mother. We don't find any reason why the decision of the mother would change by the time of day. We do check that these mothers have not been in the hospital for longer than mothers giving birth at other times of the day, so it's not really that they themselves are tired or something like that. In terms of the benefits for the mothers, well, there's a lot of literature finding worse outcomes for them as well, both in terms of physical and mental health, so I don't know if that's the case, but I wouldn't say that would be an obvious choice, let's say, at least.
Okay, thank you, Anna. I'm afraid we have to stop there for a moment. You can
Thank you
always
very
chat
much.
to Anna afterwards. Thank you. Thank you. So next we have Marianne Tenand from Erasmus, who was the joint third prize winner in 2018. And Marianne's paper is Pay Less, Consume More, the Price Elasticity of Home Care for the Disabled Elderly in France. So thank you, Marianne, and well done.
Thanks. So good afternoon, everyone. So I'm very happy to be here to give you a brief overview of our research. So I share this prize with Kitri Rogbert, and we wrote this paper when we were both PhD candidates at the Paris School of Economics. So in this paper, we ask the following questions. So to what extent do the disabled elderly adjust their use of home care to the price that they have to pay out of pocket? So as you know, developed countries are facing the aging of their population, and this means that the costs associated with the provision of long-term care services are increasing. And so in order to curb the increase in cost, most countries now promote access to home care services by implementing policies that subsidize these services. So when they design their home care policies, and in particular when they think about the level of co-payments that they want to set, policymakers have to anticipate by how much beneficiaries will adjust their consumption to the price that they pay, because this can have a high impact on public budgets. And in addition to that, you must think about the price elasticity as a parameter that captures some of the welfare properties of the home care subsidy. So think about the case in which the price sensitivity is 0. In that case, the home care subsidy programs are just a simple income transfers from the taxpayers to the beneficiaries of the scheme. But then if the elderly actually react to the price, it's important to document whether this comes from income effects or from substitution effects, because we know that this will condition the efficiency gains associated with subsidizing the use of care. So for these reasons, we think that the price elasticity is a critical parameter from both a policy and an economic perspective. But there is not much empirical evidence on its magnitude, and in order to fill the gap in the literature, we took advantage of a French scheme called Allocation Personnalisée d'Autonomie, APA, which subsidizes the use of personal care and domestic help for the 60+ that have some activity restrictions. And so the APA works as a unit subsidy on the price that is charged by the providers of care, and it comes with a co-payment that increases with the income of the beneficiary. So APA is a national policy, but it's implemented at the local level. So what we did is that we went to a department and we collected the administrative files on the beneficiaries from 2012 to 2014, and these files provide precise information on the provider prices, the APA co-payment rate, as well as on the number of hours of care being used by the beneficiaries. So in terms of empirical approach, we assume that the demand for home care is going to be a function of the out-of-pocket price of care, which is itself equal to the APA copayment rate times the price charged by the home care provider chosen by the beneficiary I. It's also a function of income and also of a bunch of covariates. So we are interested in estimating this beta 1, the price elasticity, but we are also interested in this beta 2, the income elasticity. So we have to acknowledge that the copayment rate is actually a linear function of income. And so it means that we have to rewrite the first equation in the following way, and there are two things that the second equation makes clearer. The first thing is that within the APA scheme, any variation in income will actually have two effects. So the first one is the kind of structural income effect, beta 2, but it also has a price effect, and the reason for this is that any increase in income will also increase your copayment rate and so increase the out-of-pocket price. And the second important point is that you see that this beta 1, so our price elasticity parameter, will be actually identified by variation in the price charged by the home care provider. So in the department that we got our data from, there are actually 28 home care providers charging different prices. So we actually have a quite narrow range of prices in the sample due to the fact that the market is regulated. There is not that much time variation in prices, but we still have some cross-sectional variation. So in order to address the concern that price might be endogenous to the consumption of care because the beneficiaries are choosing a particular provider, we do a number of things, and one of which is that we instrument the provider price by the number of municipalities that are served by the provider. And the rationale for this is very strong positive correlation between these two variables that you see on the graph. And we believe that there is some evidence, actually, that this might be due to coordination costs and transportation costs that grow bigger as the geographical coverage of a provider expands. So in this table, I present you the main findings from the paper. So in columns 1 and 2, you have the estimates from the equation that I showed you before. And so focusing on these estimates, you see that a 10% decrease in the out-of-pocket price of care will translate into an increase of about 4.5% of the number of hours of care being used. And you see it doesn't make much of a difference when you actually instrument the price. The other thing that we did in column 3 is that we included an interaction term for income. And so this coefficient tells you that the beneficiaries in the top of the income, in the top half of the income distribution, are actually more sensitive to price than poor beneficiaries. So two other things that I want you to get from this slide is that you see here within the APA scheme, income doesn't make much of a difference in terms of the care you receive. But remember that this variation in income was not actually capturing directly the structural income elasticity that we have to recompute. And so our results suggest that a 10% increase in income will translate into a 4% higher use of care. So it suggests that home care is a normal good. And the last thing that we did was actually to use like a back on the envelope calculation to derive the price elasticity of the XIAN, or compensated demand, which is suggested to be slightly negative, so meaning that there are some substitution effects taking place. So I will finish with this takeaway slide. Don't focus too much about the magnitude of our estimates because we don't have that much of statistical precision, but we are able to reject the fact that the price elasticity is 0 and 1. So what this implies is that any decrease in the out-of-pocket price will, at the intensive margin, increase the use of home care, but the increase will be less than proportionate. So this is what implies that the monthly or the total out-of-pocket payments borne by the beneficiaries will actually decrease following a decrease in the out-of-pocket price. And so we also find evidence of both substitution effects and income effects, and I think there are two implications that we can draw from this. One is that given that we find that richer elderly are more sensitive to the price they pay out of pocket, the fact that we have co-payments that increase with income are justified not only on equity considerations, but also on efficiency ground. And the second implication is that moving away from in-kind subsidies towards more income transfers might be a way to reduce the efficiency or to avoid the efficiency loss associated with subsidizing the price of care. And this is actually a policy option that is discussed in several countries. And so let me finish by emphasizing the fact that we need much more empirical analysis to actually better understand the welfare properties of the long-term care subsidy schemes. So thanks for your attention. So please feel free to contact us or have a look at the paper. And I would also like to acknowledge the fact that this research was part of a wider research project called MODAPA, which benefited from some external funding. So thank you.
Thank you. Okay, questions? I'm sure you've all got the hang of the format now, so off you go. Questions?
More time for...
Could have spoken for longer now. No?
It makes more time for the following.
Exactly. Okay, all done? Okay. Thank you very much, Marianne. Okay. Next paper is by Adrian Rubli from ITAM in Mexico. And it is low-cost, limited service, private healthcare providers, evidence from Mexico. Okay, Adrian, thank you. Congratulations.
Thank you. All right, this is definitely on. Does anyone know how to do the full screen? There you go. All right. So in the past 2 years, ever since I submitted this paper, I've been doing a lot of revisions to it. The main results are still there, but I've been kind of streamlining it. And one of the things that I did recently is I changed the title of the paper. Maybe I should have waited until after this. But I really wanted to emphasize what this paper is mostly about, which is the trade-offs between access and quality, and that this evidence is coming from retail clinics in Mexico. Oh, I guess I can use this. All right, so we know from a vast literature that primary healthcare provision is still a very big challenge in the developing world. And there are some private market innovations that could be an efficient solution, but it does raise a lot of questions, particularly in terms of the trade-offs between access and quality. And so there are kind of two dimensions that I care about here. The first one is, once these new private providers appear in a given health market, how do people actually respond, and how do patients change their behavior, their choice of provider? And of course, this is going to depend on people's substitution patterns. And also, to what extent might physician agency be a problem? We know that this has been documented in a variety of settings, but if we think about these types of providers, these new providers, they may, the way that they provide these lower prices and quicker service might be through diminishing quality. And so in this paper, I'm going to focus on what I call PADOs, which are private pharmacy-adjacent doctor's offices in Mexico. If you're familiar with the US context, you should think of this as the minute clinics at CVS. The only difference is that the ones in the US and in other countries are staffed by non-physicians, so nurse practitioners, et cetera, whereas the ones in Mexico are doctors. And so I'll look at substitution patterns and provide some insights on quality of care through prescribing behavior. All right, so as in many developing countries, the Mexican healthcare system, just a quick overview, because I'm sure a lot of you are not familiar with it, is a mix of public and private providers. And so the public system is mostly free, but it's very congested and thus inefficient. And the private providers, they're very expensive, and people pay mostly out of pocket, and this is due to very low private insurance rates. And so even regardless of these characteristics, conditional on receiving medical care for when people are sick, this is data from a health survey in 2012, roughly half and half of people are going to the public and the private providers. And so basically it's just saying that some people just find the private providers too expensive and are willing to wait for a really long time. Some people find the wait really expensive and are willing to pay more money. And so these PADOs, these doctors' offices within a private pharmacy, are low-cost, limited-service private providers that have been appearing. They offer limited services, mostly focusing on acute infections, respiratory infections. And they're low-cost, $3 per visit on average, low waiting times, about 20 minutes per visit. So in the paper, I talk a lot about how these PADOs expanded, and I just want to give you a little bit of background here because I obviously don't have time. But the first PADOs first opened in 1997, and there was a very gradual and slow expansion. And then in August of 2010, the government passed a law that prohibited over-the-counter sales of antibiotics. So before 2010, people would just go to the pharmacy, buy antibiotics, and this was, there's some literature that documents this as a very widespread practice and very, very lucrative for pharmacies, private pharmacies. Of course, we're talking about, and so the largest PADO expansion coincides with this law, and this kind of makes sense, right? These are pharmacies that were worried that they were going to lose some of their revenue. We're talking about a middle-income developing country, so of course regulations are not very strict, and that will have consequences, and most of this is concentrated around pharmacy chains, of course, because you need to pay the fixed cost of setting up the doctor's office. This is just a quick picture of a pharmacy in Mexico City. So this is the pharmacy. You can see the counter over there. And this little area over here is the waiting room, and there's a doctor's office back there, okay? All right, so I use a bunch of different sources of data. So first I have a roster of the PADOs with their address, which I then geocode, and their date of entry into the day when they opened. I have data on utilization rates at public outpatient clinics from the Ministry of Health. And so here I have all public outpatient clinics in Mexico, and I'm going to focus on acute respiratory infections based on ICD-10 codes that doctors themselves put in the electronic records. And the reason I focus on acute respiratory infections is, again, because this seems to be a big motivation for the PADOs, and it is in surveys, this is what people tend to say, this is like the main reason for why they use a PADO, or for why they go to a PADO. I'm now going to talk today about some results that I have using the National Health Survey, and then when I talk about prescribing behavior, I'm going to look at penicillin sales at private pharmacies. And so here I'm going to have unit sales of penicillin products by type of product. Again, these are private pharmacies, so if you go to a public provider, if you go to a public clinic, they also have their own public pharmacies, and you would get your medication there. And so these private pharmacies, even though I cannot see whether there's a doctor's office there or not, these are not overlapping with public care. And so unfortunately here the data is different. It's not weekly and it's not at the pharmacy level. It's aggregated at the city level and at the monthly level. Data limitations as always. This is just showing you very quickly the expansion of PADOs. Again, this is the antibiotics law. And so the empirical strategy that I'll follow, very simple two-way fixed effects model. So I have an outcome at the clinic time period level, a bunch of indicators for leads and lags, and then I have my time fixed effects and my clinic fixed effects. Of course, I don't have time to talk about the assumptions behind this, but I'm happy to do that afterwards. And today what I'm going to focus on is showing you the results of the first PADO that enters a public clinic's catchment area. And so essentially, because these are public clinics, the government decides where you need to go if you're assigned, or basically they assign the public clinics to the population, right? And so this allows you to really identify local health markets because people are not able to go to any other clinic. And I'm focusing on the first PADO because I want to abstract from any competition effects, and I want to just look at what happens when your choice set grows. And then for the penicillin sales, I'm going to look at PADOs per capita at the city level because of the data limitations that I mentioned. So the main results from the event for the effect of the first PADO on public outpatient utilization for acute respiratory infections, pretty flat before entry, which is good. So this kind of indicates that entry of the PADO into the health market is not driven by sudden changes in acute respiratory infection utilization in public clinics. And then we see this gradual decline, and it stabilizes, and this implies a reduction of around 7.5%. And so what this is telling me is that when these PADOs enter these health markets, they're actually stealing patients away from the public clinic, okay? I'm going to skip the robustness checks. Well, I'm going to talk quickly about this. So there's been a recent literature talking about the two-way fixed effects models and how it might be problematic when you have heterogeneous treatment effects. And so a few economists have developed these walled estimators that are robust to this. And so here what I do is I extend the window and this estimator to show you that I really am getting something that is regardless of heterogeneous treatment effects, there is no pre-trend, and then there's this very clear decline in utilization. Right, and so then just very quickly in terms of penicillin, because I'm sure that I'm out of time. Am I out of time? Okay, I still have 2 minutes. So then in terms of penicillin sales, so like I mentioned, one of the main reasons for why people go to these PADOs is for acute respiratory infections. And so there's all this literature talking about patients that are seeking antibiotics, doctors that think that patients are seeking antibiotics, and this kind of loop back and forth. And so this kind of just motivates me to think about looking at antibiotic sales in particular. I only have penicillin sales. This is a data limitation, of course, but at the same time, penicillin is the most prevalent antibiotic still used in Mexico. And so broadly speaking, and this is an overgeneralization, and I apologize to any epidemiologists or people who are better trained at this than me, but broadly speaking, there are 2 types of penicillin. A basic type, basic aminopenicillin, and then a combination with a beta-lactamase inhibitor, which just means that it's a stronger type. Of course, these stronger complex combination penicillins are more expensive, and so they lead to more revenues for pharmacies, for private pharmacies. And so I run the two-way fixed effects model. I messed up the table because I didn't want to break it out by also generic versus brand name. So just focus on kind of like the first 2 rows, just put them together and think of this as just the effect of PADOs per capita in a city on the unit sales per capita of basic penicillin types versus complex penicillin types over here. And so what I'm seeing is this big shift towards the complex types with a decrease in the basic types. And so given the controls that I'm including, if you're willing to buy that I'm capturing any epidemiological trends that would be relevant, and if you're willing to accept things that I haven't shown you right now, which is in terms of patient selection and who is going to these clinics, it seems that this is driven more by the financial motivation of doctors at these private PADO clinics. Up the summary of the results. So I showed you today a significant substitution away from public outpatient clinics when a PADO enters a local market. I didn't show you this today, but I don't find any evidence of an increase in overall utilization. So I don't see evidence of new doctor visits, which is one of the kind of main arguments that some people in public opinion have put forward to justify the introduction of these types of not very well-regulated providers. And I also showed you this strong shift in the composition of penicillin sales in private pharmacies, which may suggest that there are these negative consequences on welfare due to the incentives that these physicians have. All right, and thank you very much. And if you have any comments, I would be happy to get them. There's my email. Thank you.
Thank you. Okay, thank you, Adrian. Questions, please? Question at the front.
I'm afraid it's not about your paper, but it's about how that market is evolving. So the other thing we're seeing in similar places is the development of e-pharmacy, often with associated e-prescribers, right? So you can't buy your medicine over the internet without getting somebody in like Bulgaria to write a script for it. Are you seeing that in Mexico yet?
So we haven't really seen much of that happening in Mexico. I think that does, I have thought about that because I have noticed that this is prevalent in many contexts. I think the reason for that is that there's still very low penetration of internet usage and computers. Yes, people have smartphones now, and that is mostly how people access the internet today in Mexico, but a lot of people just don't have a computer at home or access to the internet. But it would be interesting to see whether in the following years, as there's probably more market penetration of internet services, whether those kinds of things would also appear, and how they might interact with these other providers. Thank you.
Okay.
Another question?
Last question.
Quick question. So how much do patients pay to see a doctor at the PADO? I mean, I was wondering, because before of the regulation, they could just simply go to the pharmacy and get their antibiotic. And after that, they have to see this doctor, right? And they even probably pay a price. So on an aggregate level, do you see less antibiotics prescribed? I mean, this could be even beneficial, right?
Right. So one of the things that I'm seeing, so I don't really have very clear data from the health survey that allows me to really see differences in who exactly is prescribing what. The only thing that I can observe there is the number of medications. And even though, yes, the number of medications prescribed at PADOs is higher on average than at public clinics, the difference is not, a t-test doesn't show that this is a significant difference. So who knows what that means. At the same time, yes, there's a lot of kind of back of the envelope calculations that I've tried to do. Of course, there's a lot of assumptions behind that, where you're thinking about, you know, there's this time cost of going to the public clinic, but I'm not gonna pay for the doctor, not gonna pay for my medication. But I could also just wait there, see the doctor, and buy my medication elsewhere. Or I could just go to the PADO, I'm gonna pay on average $3 to see the doctor, and then I'm still gonna have to pay for my medication. And so it's kind of complicated to get a sense of what people are doing. But I'm really looking forward to doing things along those lines. And for example, trying to see if people actually buy all the medications that the doctor at the PADO prescribes. If they're just hunting for antibiotics, they might get prescribed 3 medications, but just buy the antibiotic.
Okay, thank you, Adrian. Well done again.
Thank you. I think that's it.
Okay. So, lucky last, the third prize winner, 2019, is Panka Bensic from the University of Sussex. And the paper is Stress on the Sidewalk, the Mental Health Costs of Close Proximity Crime. Thank you, Panka.
Thank you. Okay, thank you for sticking with us today. So I would like to talk to you about how there are externalities to crime in terms of mental health beyond the victim. So my question is, do violent and sexual crimes affect those beyond the victim? And crucially, what I want to separate is whether there are simply neighborhood characteristics that have an effect on people, or there is an additional recent crime effect. The reason I'm doing this is that as much as with many other externalities, with crime, much of what we capture, if we only think of costs in terms of policing and the criminal justice system, we are missing a part. So this is back to Becker arguing that what we usually consider in terms of costs of crime is missing serious parts. And then there is a similar other side of the argument that the World Economic Forum suggests that about 2/3 of mental health costs are indirect costs. So there is some research on these externalities of crime. There's more on behavior, there's less on mental health. And both of these papers look at kind of broader crime rates. So my geographical level is 1,000 times smaller than what they use, and then I'm looking at daily level as opposed to quarterly or annual rates data. So what I'm wanting to move from kind of broader rates to a literal crime a couple days ago right here. And I do this because mental ill health is very costly and stress is very costly. Let me tell you a little bit about my 2 main data sources and then some additional data. So my data comes from the Thames Valley region of England, which is about 2.1 million residents. It's directly west of London. So if you're familiar with the US context, then it's kind of like Long Island. That is next to New York. So this one is right next to London. It's next to Metropolis. It has urban and rural areas. Oxford is, for example, a city in this, or Milton Keynes. And I have data on every single reported crime in this region between 2010 and 2017 with the exact GPS location of where the crime happened, the time of the crime, and the type of the crime. So this is certainly secure access data, very, very detailed. And exactly because it's so detailed, I have to aggregate it to some levels. So I'm looking at the number of crimes per day in a very small area, and the small area is called an output area. This is the smallest UK geographical area. This is about 131 households, so it's about the size of a street. If you want to compare it to US zip codes, it's about a 20th of a US zip code. So this is pretty much a spot where from one vantage point you can see it. So what I'm asking, what happens if a violent crime happened right here on this street a couple days ago? My stress data comes from a daily response panel data set that's called Mappiness, and it's a smartphone application, which is a generalized well-being survey. So this is a survey where anybody can join, and when it was introduced, it was very popular. There was a lot of media coverage of it, which means that it reached a quite wide audience, and what is important, that it was never introduced as a mental health survey or targeting a subpopulation in any way, but it was designed as kind of a population-wide, if you are interested in your happiness, if you want to learn about yourself, then you can join. And exactly in line with that, the motivation for participation was feedback for the individual. So if you took part for a couple of days, then you started seeing little graphs of who you are the happiest with and how your happiness has been changing over time, and that was the reason people took part. Once someone signed up, they would be twice a day at random times, and at that time we also pulled their location. What is important is that this is a non-representative survey exactly because anybody can join, but in exchange for that, there are 3 million plus responses from the UK, and within that, there are 1,500 residents of Thames Valley, and then another additional, a total of 5,000 individuals who might not reside, but visit Thames Valley regularly. I do that as a robustness check, but for now, I'm gonna show those who live there, so most of the responses, we are aware of what level of crime it is treated with. And the circumstantial control, so this is a lot of data sets here. I want to avoid misattributing the connection between crime and mental health to, for example, it's raining, right? Or it being sunny, or it being the evening. So I control for air temperature, sun, cloud cover, speed, wind speed, rain at the exact location and time of the response, as well as whether it was daylight. I control for a lot of temporal effects, so that is year times month fixed effects. So this will take out every election or an unexpected natural disaster or anything that is kind of like a one-off effect. I control for day of the week and hour of the day. And I use, crucially, local area fixed effects. So I control for what is the effect of being in a sketchy neighborhood. And what I'm asking is that beyond this neighborhood being what it is, what happens if there was a violent crime a couple days ago? Express the same thing in the empirical strategy. I'm estimating the level of stress with the most recent time periods crime, and then I have 3 fixed effects, individual, location, and time fixed effects, plus all of those weather controls. Okay, so let's move to the results. So we are making our way to column 5, which is my preferred specification, and I'm looking at the last 3 days. If in the last 3 days there was a violent or sexual crime, then even with all of the controls added, I find that if there was a violent or sexual crime in the last 3 days, then stress levels go up. One thing I want to highlight to you is that other crime is every crime that's not violent or sexual. This is predominantly property crimes and theft. Add these last 2 geographical controls, it seems that both are significant. So if you are in an area where there's lots of pickpocketing happens, you might be stressed about it. But an additional pickpocketing yesterday does not matter. However, an additional violent crime yesterday does matter. So getting so precise with the geographical temporal aspects allows me to separate channels that we might have not been able to separate before. Okay. So far, what I talked to you about is that in the last 3 days, if there was a violent or sexual crime, stress goes up. I want to decompose the temporal aspect. So if I take apart this effect day by day, so if there was a violent crime yesterday, 2 days ago, 3 days ago, then I interestingly find that it is violent crimes 2 and 3 days ago that drive the stress result. It isn't violent crimes yesterday. So if that's the case, that yesterday's crime doesn't matter yet, it's 2 and 3 days ago, then there's going to be a channel of the information. It takes a day to get to you. So in the final section of the paper, I think through what could be the potential mechanism that it takes an extra day for the crime to have an effect on your mental health or on your stress levels. And we can think of a couple mechanisms. Word of mouth, you get home and your partner tells you that they have heard someone was stabbed on the street. It could be local forums, so Facebook groups are pretty popular, kind of local Facebook groups right now, news media, local news, national news. And in this, what I explore is national news. So I look at The Sun and The Guardian, which are 2 British national daily newspapers. I scrape some data from them, and what I find is that if yesterday there was a crime-related article on the front page in the news section, so this is not movies about criminals, but actual news about crime, then stress goes up, regardless of the paper. So, to conclude, violent and sexual crimes increase stress for those in the vicinity, and this is true for about 3 days, and the effect is for about 250 individuals. I do a bit of a calculation also on costs. I'm happy to speak to that if there's an interest. And as I said, there's a lag between treatment and response, and one of the mechanisms I suggest is news media. So the contribution of the paper is threefold. This is the first paper to show the effect of individual crimes on stress in the case of common crimes, so not terrorist attacks, but kind of regularly occurring crimes. Because of that, it's also the first to speak to the dissipation of the effect. So instead of talking about crime rates, talking about what is the actual effect of one violent crime having happened and how long it lasts. And then, as I mentioned, I measure crime rate at various locations for the individual, and I find that all of those locations matter. So it's not only crime level around your home, but also around your work and where you go to the gym and where you meet your friends in the pub, which has policy implications for example, crime-heavy pockets in a city. And the broader relevance is that finding that there is this mental health cost suggests that crime is costlier than we thought, and crucially, how costly in proportion violent and other crimes are seemingly is different than we have assumed, not counting this cost. Okay, thank you.
Thank you, Panka. Okay, wow, look at this. Okay, 1 and 2. Thank you.
Thank you. Very nice presentation.
Thank
I
you.
wanted to ask 2 quick questions. The first is whether you can help us interpret the magnitude of the intensifying, and the second is whether you've explored any heterogeneity by the average crime rates of the places, because I'm thinking that maybe if crime is more unusual, then the effect of a crime could be more shocking and have a larger effect on stress and so on.
You just have to be a little bit quick with the answers because we're getting close.
Should I take a couple questions and then try to...
Just answer that one quickly then. All right, okay. So there you go.
Okay, so for the first question, the size of the effect, so it's about a 1 percentage point increase, which is exactly the kind of number that to me feels simultaneously small and large. So it's not a big effect for one crime, but this is a crime that happens thousands of times a month. So that ends up being a big social effect. And then your second question, in this paper, I'm not looking at kind of the cumulative effect of crime. So there's some evidence that you might become desensitized. There's some evidence that you might become cumulatively impacted or even exponentially impacted. But in this paper, I'm not looking at that. I was very curious exactly about this kind of the one-to-one relationship.
Okay, thank you. So if anyone wants to ask any of the speakers any more questions, This has been recorded. You can look at all their email addresses on the internet and talk to them afterwards. So just a couple of quick things to say. Thank you, Panka, and congratulations.
Thank you.
Okay, two quick things before we go. Monica said something important earlier. Okay, this is a highly competitive prize. We have about 50 papers every year judged around the world by a highly skilled committee. But if you don't enter, you're not going to win, okay? So the call comes out in October. Monica said she probably thought twice about entering, right? But if she hadn't entered, she wouldn't be sitting here. So please do enter. The actual deadline for entering is January, but the call goes out in about October, so you've got plenty of time, and it's open to masters and PhD students, okay? Second thing to say is the students, who are probably, some of them not students anymore, will be receiving their certificates tonight at the plenary up on stage, and I know they're very excited about that. So please do come along and see that happen as well. And if you have any further questions, my name is Bruce Hollingsworth. I'm the chair of the student committee. I'm at Lancaster University, the UK. You can find me on the internet. Please email me if you've got any questions. So thank you all very much for listening online and for coming along this afternoon. And especially, thank you to all our winners who are wonderful. Thank you very much.